Today we will speak about the spinal cord, yes, about the macroscopic structure, and next week we continue with the histology. At first it would be important to know where the spinal cord is to find. It is the lower part of the central nervous system, and if you remember, it is found in the so-called spinal canal. Yes, you have to repeat the vertebrae a little bit, but in this picture you can see the vertebral foramen, which is enclosed by the arch of the vertebrae and the body of it, and then all the vertebral foramina together form the spinal canal. But not only bones line the spinal canal, but we also have ligaments. If you remember, posterior longitudinal ligament at the dorsal surface of the body of the vertebrae, and between the arches of the vertebrae we have the ligament of Lava, which then line the spinal canal as well. In this lateral view, you can see the intervertebral foramina. This will be also important for us because here the spinal nerves exit from the spinal canal, and then if we open the spinal canal from the dorsal side, as you can see in the picture, then you can see the content. So naturally the spinal cord is located here inside of the canal. The spinal cord starts here from the medulla oblongata at the level of the foramen magnum. Yes, so below the foramen magnum it starts, and you can also see that in this next picture that it terminates about at the level of L1 of the vertebra L1, in newborns a little bit deeper, L3. So that means that the spinal cord is shorter than the vertebral canal because the vertebrae grow much intensiver and much more intensive, and that means that the nerves which have to exit, they always have to find their own intervertebral foramen. And if you check it, this so-called nerve roots, these are called which exit and enter the spinal cord. You can see on both sides of the spinal cord these nerve roots. Yes, these are also located inside of the spinal canal, and at the level of the cervical vertebrae, they run relative horizontally, but in the thoracal here and lumbar parts, as you can see, they must descend to reach their own intervertebral foramen because the spinal cord is shorter than the spinal column. And in the lower part of the spinal canal, we only have a bundle of these nerve roots, and it is called cauda equina, so horse's tail, if we translate it in English. The lower end part of the spinal cord here, it is called conus medullaris. So this is the end part actually, and from here the so-called filum terminale originates. That's a very thin fiber which doesn't have any nervous tissue anymore, only connective tissue. Actually, this is the continuation of the pia mater, the innermost layer of the meninges, and it exits here the sacrum through the sacral hiatus, and it is fixed to the coccyx. So it is important for the fixation of the spinal cord. It's about 25 centimeters long, and you will see that it has another color than the nerve roots, so we can distinguish it from the nerve roots. So I change my show. think this, yes. Okay, then as you can also see that the spinal cord and these nerve rootlets are surrounded by the dura mater. This is the outermost layer of the meninges. We will also speak about these layers. But here you can see an anatomical preparation of the spinal cord. Altogether, the length would be about 45 centimeters and the diameter is it ranges between 6 and 13 millimeters. And it can be divided in more parts into a cervical part, into a thoracal, a lumbar, and a sacral part. But I want to emphasize that it is not segmented. Yes, so on the outer surface we cannot see any segmentation. And you can also see here this dura mater. So as I mentioned, the diameter varies because in the cervical and in the thoracolumbar or lumbosacral, I would say, lumbosacral parts, we have enlargements of the spinal cord. These are called intumescences. So the cervical one extends from C5 to T1 and the lumbosacral from L2 till S2. These are the areas where these large plexus, the brachial plexus and the lumbosacral plexus originates. And these are the plexus which supply the upper and the lower limb. And that's why we have more neurons in these areas. Yes, we can also see some outpouchings. These will be the dorsal root ganglia. So what are these meninges which surround the spinal cord? The function of these meninges is to protect the spinal cord, and we can distinguish between hard and smooth layers, and the dura mater, this is actually the so-called pachymeninx in Greek. This is the hard layer, but here around the spinal cord it can be divided into laminae. The external lamina is here visible. This is what actually lines the spinal canal. It corresponds to periosteum of the bone, and it can be also called endorachis. Rachis means spine in Greek. And then we have the dura mater proper. This is actually the internal lamina, which we also saw, which we have also seen in these previous pictures. And here you can see it as well. It is made up of dense connective tissue. You will see it also in our preparations. And between the two layers, we have a space called epidural space, which is filled with adipose tissue, and we can find a very big venous plexus here called internal vertebral venous plexus. Then, if we fold up the dura mater, we have the arachnoid layer. It also belongs to the leptomeninx, so these are the smooth layers of the meninges. And the arachnoid is very thin. It's composed of loose connective tissue, and it has a spider web-like appearance. And it is attached to the inner surface of the dura mater, so we do not have actually this subdural space under normal conditions. This is only a capillary space because the cerebrospinal fluid found under this layer pushes the arachnoid to the dura. And the innermost layer is called pia mater. It surrounds directly the spinal cord. It follows the surface of the spinal cord and also the nerve roots. And it also goes into the grooves, you will see. And it is also composed of dense connective tissue. And this space is then very important between the pia mater and the arachnoid, called subarachnoidal space, because here we have the cerebrospinal fluid. And one more structure I want to mention here. These are the so-called denticulate ligaments. These are frontally visible ligaments, and these also correspond to the stabilization of the spinal cord. They originate from the pia and go to the dura, and between two rootlets, between two spinal roots, we can find them, and these structures you will also see in our histological slides. This picture here shows a cross-section now of the spinal cord and the meninges. You can recognize here the two layers of the dura, external and internal layer, and between the two layers the epidural space filled with adipose tissue and veins. In this picture should be here this number 4, this epidural space, and you can also recognize the dura, number 3 here. And if you follow these layers, you will see that the dura will continue in the epineurium of the nerves, of the spinal nerves, and the arachnoid will continue in the perineurium of the spinal nerves. And you can see here that in the intervertebral foramen, we will also find, so this is the area where the spinal nerves will be formed, and here we will also find the spinal, so this dorsal root ganglia. And this picture shows that the dura sac extends as far as the second sacral vertebra, but in the lower part we do not have anymore the spinal cord, only these nerve root bundles. And here, in the lower part of the dura sac, we usually do the lumbar puncture. This is an intervention to take a sample from the cerebrospinal fluid for diagnostic purposes. And you can see here how to find this lower area of the spinal canal. It can help if you connect the two iliac crests with each other, then you will be at the level of L4 about, because this intervention must be made between L2 and L4, so where we do not have any spinal cord anymore, only these nerve root bundles. And you can see that here we have to pierce at first the ligament flava, which is between the vertebral arches, and the patient must bend forward a little bit so that the spinous processes will be moved from each other, and then you have to pierce the dura as well, and then you will reach the subarachnoidal space where we have the liquid with this cerebrospinal fluid. And with the same intervention, we can carry out the spinal anesthesia as well. As you can see a small animation here. So a needle must be inserted through the ligament flava and then through the dura, and then if you inject an anesthetica, local anesthetica, into the dural, into the subarachnoidal space, then we have the spinal anesthesia, which will have a rapid effect because it mixes with the cerebrospinal fluid, and the rootlets will be then anesthetized for purposes of surgeries or for pain management. It is done, and then we will have an analgesia in the entire lower limb, and also an autonomic and sensory and motor blockade. At first, the autonomic blockade will appear, so you will see a vasodilatation in the lower limb, and then the sensory blockade comes, and at the end also the motor blockade. And there is another method to anesthetize these roots. This is the epidural anesthesia, but in this case, as you can see in this animation, the local anesthetic will be injected into the epidural space. So the dura won't be pierced. And that's why the effect will be a little bit slower, but it can be done at different levels, depending of the purpose. So in case of thoracic surgery, for example, it can be done at the level of T6, 7, or in case of lower limb surgery at the level of 3 and 4. And you will have, in this case, a bed-like anesthesia. And very frequently it is used during delivery to relieve the pain. But now let's go further, and in this picture you can see the cross-section of the spinal cord, and you can see that we have an outer part, and this outer part is the white substance. In the white substance we always have the axons of neurons and also glial tissue. And the gray substance is located in the center, so that means here we will find the cell bodies of the neurons, the dendrites with synapses, and also the starting portions of the axons, and these are unmyelinated axons in this area, and naturally also glial cells. And in the center of the gray substance, we have the central canal. This is the continuation of the fourth ventricle. And you can see that on the anterior side, we have a deep groove. It is called anterior median fissure. And posteriorly, the groove is not so deep. It is called posterior median sulcus. And the gray substance can be divided in horns or columns if we speak about about the three-dimensional structure. So we distinguish a posterior horn. This is a little bit elongated. It reaches the surface of the spinal cord. We have an anterior horn or column, and we also have a lateral horn, but only at the level between T1 and L2, so not in the entire length of the spinal cord. And the white substance can be divided in funiculi, posterior funiculus, lateral and anterior funiculus, and they reach here. So the borders are these grooves where the nerve rootlets enter and exit the spinal cord. This will be also visible in the next slide. And but you have to understand that the axons can form tracts, pathways. Yes, schematically you can see here ascending or descending pathways which are found in the funiculi, or the axons can exit the spinal cord, can leave the spinal cord, and you will also have axons entering the spinal cord. And these are the so-called rootlets. You can see that the nerve fiber bundles exit continuously. So under each other you have lots of so-called nerve rootlets. We have it anteriorly and also posteriorly, and they will then unite and they will form the so-called roots. We have posterior root and anterior root, and the roots will then fuse with each other at the level of the intervertebral foramen, and they will form the spinal nerves. And you will see a thickening on the posterior root, and that will be the dorsal root ganglion. But these are also here visible. So once again, a cross-section. You can see it from the spinal cord with the anterior median fissure and posterior median sulcus. And if you check it, in this anterior view, this groove where the anterior rootlets exit, this is called anterolateral sulcus, and this is the border between the anterior and lateral funiculus. And this is also called motor root, which is formed from these motor rootlets, because you will see here will exit the motor fibers, motor axons. And so the anterior root is formed by about 8 to 12 anterolateral or ventral nerve rootlets. And on the dorsal side, we have similarly dorsal root. It is called in the posterolateral sulcus. The rootlets exit, and I should say enter, because here you will see here will enter the sensory fibers. So the dorsal root is actually a sensory root. And then here you will find a thickening, that will be the dorsal root ganglion, and then where the two roots unite, then we'll speak about the spinal nerve. And the spinal nerves always divide into a dorsal and a ventral ramus. You have already learned it. And in this picture, you can also see the sympathetic trunk, which is also connected with the spinal nerves. So please switch off the microphone. Thank you. With the communicating rami. And one term I want to emphasize, what is actually the spinal cord segment? Yes, because the spinal cord itself doesn't show any segmentation, but that part of the spinal cord where a pair of spinal nerves forms, that is the spinal cord segment. Yes, so it is formed by the anterior and dorsal roots, which then unite and form the spinal nerve. And you will see it in histology as well, and we will speak about it later as well, but this schematic drawing shows what kind of fibers we have in these roots, in these rootlets. So the dorsal root contains always the sensory fibers, both the somatosensory and the viscerosensory fibers, which enter the spinal cord. Yes, in the posterolateral sulcus. And if you follow this blue line, so please switch off the microphones. Someone has switched it on. So if you follow this blue line, it starts in a receptor. Yes, so this is the nerve ending of a sensory fiber. And if you follow it, you can find the soma cell bodies of these neurons in the dorsal root ganglion, with the pseudo-unipolar cells, and the central process is what we actually have in the dorsal rootlets, and they enter the spinal cord. And on the ventral side, we will have the motor fibers. As you can see, the cell bodies of the somatomotor neurons are located in the anterior horn. The cell bodies of the autonomic nerve cells are located in the lateral horn, but both axons exit the spinal cord through the anterolateral sulcus and form the ventral or motor roots. Yes? And then the spinal nerves are mixed, as you can see. They contain both sensory and motor fibers, and the autonomic fibers will be also form a second efferent in an autonomic ganglion. Yes, so what I want to emphasize is that the spinal nerves are mixed. And the dorsal root ganglia you already know histologically. Yes, you can see here the pseudo-unipolar neurons. And what I want to emphasize is that these ganglia are located in the intervertebral foramina. And we only have 30 pairs of these ganglia because the segment C1 doesn't have any sensory fibers and any sensory ganglia. And if you check the schematic drawing, you can see that we have altogether 31 pairs of spinal cord segments and 31 pairs of spinal nerves as well, because from the cervical part we have altogether 8 pairs exiting, yes. And you have to a little bit compare it with the number of vertebrae. Yeah, if you remember, we only have 7 cervical vertebrae, but as you can see, the first cervical nerve exits between the atlas and the occipital bone. So that means that in the cervical part, the nerves always exit above the vertebra, and then the last nerve will be that nerve which exits under the C7, yes. And in the other areas, so in the thoracal and lumbar and sacral parts, the nerves always exit under the corresponding vertebra. So we have altogether 12 pairs of thoracal and 5 pairs of lumbar, 5 pairs of sacral and 1 pair of coccygeal nerves. And as you can see, the roots must descend to reach the appropriate intervertebral foramen. And you can see here on the left side that the thickness can also vary, the thickness of the anterior horn and the thickness of the spinal cord. And that's also important that the spinal nerves always form in the intervertebral foramen. So that means that the spinal canal contains always the roots, yes, the nerve roots. And at the level of the intervertebral foramina will be the fusion of these roots, and then we speak about spinal nerves. And this is what you already know, the further course of the spinal nerves. So the ventral rami of the spinal nerves form the plexus. At the different levels, we have different plexus. The only exception is the thoracal part, where the ventral rami do not form plexus. Here we have the intercostal nerves, which actually correspond to the ventral rami of the spinal nerves. And just let's compare the so-called segmental and peripheral innervation. Here you can see schematically how the segments are formed, and you can see that in the plexus we have nerves coming from more segments, and that is also in case of peripheral nerves. We can have fibers coming from different segments in a peripheral nerve. But then, in case of the sensory innervation, you will see that one segment of the spinal cord will innervate a stripe of skin, so a skin area, which looks like here. You can see it. So these are the so-called dermatomes. That means a skin area which is innervated by one segment, and you can see that they overlap with each other. But if you compare it with the peripheral innervation, so if you take a peripheral nerve, for example, radial nerve, you will see that the skin innervation will be different, because in a peripheral nerve you have fibers coming from more segments, and one dermatome gets also fibers from more peripheral nerves. So I want to emphasize that the segmental innervation and the peripheral innervation is not the same. And clinically, we could mention the herpes zoster. That is a viral infection, and the viruses can be stored in the dorsal root ganglia. That means that the symptoms will appear according to the dermatomes, according to the appropriate dermatome. And in this case, for example, are the segments between T9 and 10 affected, and you can see the vesical eruptions in this area, and patients will also have pain according to this dermatome and sensory loss. And that's the same in case of the motor innervation. One muscle can be innervated by fibers coming from more segments, but one of the segments predominates, so it can help us. It can be also used for diagnostic purposes. For example, if you carry out the triceps reflex, and if you have a problem with this reflex, then it can refer to the problem in case of the C7 segment. But as you can check, one peripheral nerve is also composed of fibers coming from more segments, but one muscle is innervated by mainly by one peripheral nerve. So some clinical aspects I want to emphasize. The discus hernia. You have probably heard about it. It means if the nucleus pulposus of the intervertebral disc protrudes through the annulus fibrosus, and it compresses then either the spinal cord or more frequently the spinal roots. It is called then dorsolateral herniation, and it's interesting that in this case not the appropriate root is compressed, but the root below, so between L4 and L5, where the L4 exits, it is intact, but L5, the nerve L5 will be compressed. And according to the segmental innervation, the symptoms will appear according to the dermatomes. Yes, as you can see here. For example, if you have a problem with the L5 root, then the pain will radiate toward the big toe, and the patients will also have paresthesia. That means pins and needles they can feel, or partial or total loss of voluntary movements can also appear. And you can, so according to the symptoms, you can know where the lesion is found, at which level. Another very common problem is the low back pain, or lumbar or sciatica, it can be also called. You probably know it. So if you lift something, for example, or in twisting, forward bending movements, a sudden sharp pain can appear. This pain can be also radiating, then we speak about sciatica. And then the patients cannot move anymore because the pain is very, very strong. And it can have more reasons, but mostly we can see the degeneration of the intervertebral discs. You can compare these discs that can be degenerated, and as a consequence, the spine will get shorter, and then the intervertebral foramina will get narrow, and the capsule will be much looser, and then it comes to the incarceration of the joint capsule and the nerves, so the spinal nerves get compressed, and that is the reason for this pain, and because the muscles will then will be contracted. Or other diseases, tumors can be also found in the spinal, around the spinal roots. These tumors can be extradural. For example, if you have a bone carcinoma, a bone tumor, osteosarcoma, or they can be inside of the dura, so intradural but extramedullary, or there are also tumors of the spinal cord itself, the intramedullary tumors. But two examples I want to only show you. The meningioma, this is the tumor of the arachnoid, and this is quite common, and it belongs to the intradural extramedullary tumors, and it looks like an hourglass, so it can be also called like this. Or the other tumor is the neurinoma, it starts from the Schwann cells, and it is also an extramedullary intradural tumor, and it can also compress the spinal roots. And you will see that these tumors mostly appear on the surface of the spinal cord, where the oligodendroglia and the Schwann cell transition is located. We will speak about these tumors also later. But now let's continue with the blood supply of the spinal cord, and here you can see the vertebral artery in this picture. This artery comes from the subclavian artery, and it ascends through the transversal foramina of the cervical vertebrae, and then it enters the intracranial space through the foramen magnum, and the two vertebral arteries fuse and form the basilar artery. But before they fuse, they give two branches, the anterior and posterior spinal arteries, and the anterior spinal arteries fuse with each other, so we will have one piece of it which runs in the middle of the anterior surface, but the two posterior arteries do not fuse with each other, so you can see in a cross section these arteries. We should have here another posterior one, and as you can see, these arteries form an anastomosis with each other here. This is called vasocorona or arcuate branch, and as you can see, this vasocorona supplies mainly the white substance, the lateral and anterior funiculi. The posterior spinal artery supplies the posterior third, that means the posterior horn, the posterior funiculus, and the dorsal root. And the anterior one gives a branch toward the anterior median fissure. This is called sulcocommissural artery, which supplies then the 2/3 of the spinal cord. Yes, so the lateral and anterior horns, the central gray matter around the central canal. So this is the most important artery here, and as you can see, the gray substance is much more capillarized than the white substance. But these spinal arteries are very thin, and that's why if you check this picture here, so here this is the anterior spinal artery, but it would be very thin alone, so it must be supplied by other arteries as well, and these other arteries are the so-called spinal branches. As you can see here, the spinal branches enter then drain to these anterior or posterior spinal arteries, and these arteries originate from more arteries. In the cervical region, they come from the subclavian artery, as you can see here, mainly from the costocervical or thyrocervical, or in the thoracal part, they can originate from the posterior intercostal arteries. So these spinal branches originate mainly from segmentally arranged arteries, or in the abdominal part from the lumbar arteries of the aorta abdominalis, or they can also originate from the sacral lateral arteries. And I also want to emphasize that not all of these spinal branches are strong, so lots of them are very thin, but mainly we have one or two very strong spinal branches, and these arteries are called artery of Adamkiewicz. So these are the especially strong spinal branches. They mainly originate from T8 to L1 from one of the intercostal arteries, but not always. You will see it. And this Adamkiewicz artery is very important for the blood supply of the thoracolumbar part of the spinal cord. And you can see that the spinal branches enter the intervertebral foramen together with where the spinal nerves exits, and then they will divide into an anterior and posterior radicular artery, which then drain into the spinal arteries. So they accompany the spinal roots, and that's why they also have to ascend to reach the appropriate segment, as you can see in this picture. And here I want to speak about a clinical case, and maybe then you will understand better why this Adamkiewicz artery is important. So in a patient, the adrenal gland was removed due to a tumor. Pheochromocytoma was this tumor, and if you remove the adrenal gland, naturally you have to clamp the corresponding arteries. And in this patient, the Adamkiewicz artery originated from one of these suprarenal arteries, and as a consequence, the patient had a palsy of both lower limbs because the thoracolumbar part of the spinal cord get necroted. Yes, so this Adamkiewicz artery can originate from not only from the intercostal arteries. And another clinical case, in the case of the spinal cord, we also can have a stroke. The spinal stroke is not as common as the brain strokes. It can have more reasons. And in this case, what you can see in this picture, this is the stroke of the anterior spinal artery, and the corresponding areas are necroted. That means the patients will have analgesia, sensory loss, because the spinothalamic tract is located in this area, and they will have a palsy and also incontinence. But you will understand it if you only know the pathways of the spinal cord. And at the end, some words about the veins of the spinal cord. I want to say, we have already mentioned that in this epidural space we have the internal vertebral venous plexus, and here you can see it also in the schematic drawing, and it communicates with the external vertebral venous plexus. It surrounds the vertebral column also in the anterior, on the anterior side. And I want to emphasize this vein, which pierces the vertebra. This is called basivertebral vein. This is also a communication between the internal and external venous plexus. And you will see why is it important. But then the blood will flow toward the posterior intercostal arteries in case of the thoracal segments, or in the abdominal part into the ascending lumbar vein, which is located directly next to the vertebral column. And the continuation of this ascending lumbar vein is the azygos and hemiazygos vein. So the blood will be go in this direction, and the azygos vein then drains into the superior vena cava. And this basivertebral vein has a clinical aspect. So in these veins we do not have any valves, and in case of an increased abdominal pressure, it can happen that the blood flow turns back, and this is in the background of the bony metastasis in case of tumors, for example, in case of prostate carcinoma, because the venous drainage of the prostate is towards the external venous plexus, and through these basivertebral veins, the tumor cells can reach the vertebrae. Okay, so I have finished now, but if you have questions, please tell me.